Good afternoon, ladies and gentlemen. It is indeed a new day, a bright Sunday, a day that the Lord has made, that we should all rejoice and be glad in it. We don't like this day. Which other day would you prefer to have? Today is yet another episode of Health Issues, bringing to your doorsteps right from Richmond Media. Therefore, we do encourage our listeners and viewers to join us this afternoon, and also to thank you for being with us throughout the year up to this point. Without you, it is impossible to bring up the program. Therefore, we do appreciate your time, your everything that you are putting in to make this program successful. Today's episode the title is Preventive Measures of Gastroesophageal Reflux Disease. At the end of the program, we will all understand what this long name represents and why we are bringing you this program. At this point in time, or in time like this, we have to bring you a program like this that will help us create awareness and also to enlighten us of what we have to do in order to prevent ourselves from this disease and any other condition. Therefore, I would like to, at this moment, introduce to you my panel for this discussion. The first one, as you know, without him, I can't move by the grace of God. That is my own brother George Ackon. Brother George, you're welcome to Richmond Media.
Thank you.
How are you today?
I'm highly favored by divine selection. Just that the weather is just cool. So we are in cool season. So I'm fine by his grace.
Thank you. And the second person joining us is our brother Enoch Amofa. Brother Amofa, you're welcome to Richmond Media this afternoon. It looks like Brother Amofa's network is not responding yet, but as soon as he gets onto the program, you will definitely hear his voice and possibly see him as well. Brother George, now it's you and me. If we are lucky, we will have Brother Amofa on board. Could you please give us the overview of this program?
Okay. I think Amofa has joined, so I've added him again.
Okay. Brother Amofa, are you with us? Oh,
yeah,
you're welcome.
Thank you, madam. Good afternoon.
Good afternoon. So I have the two gentlemen with me. Without wasting much time, would you be able to give us the overview of the program? Thank you.
Okay, so good afternoon to you and to our cherished viewers. So today's topic, gastroesophageal reflux disease, popularly known as GERD. Depends on the school you attended and where you are located. Some will say GERD, some will say GERD. But it's all about we are talking about the gastrointestinal tract, or some will say GIT, or our alimentary canal. That's locally how some also will call it. So we are going to know what this disease is, and then what really it's all about, how we can manage it if we have such, and how we can also prevent it. So this the presentation outline. So definitely we would know what we are in for this presentation, what are we going to benefit from it at the end of the day. and also to, just refresh our minds, those of us who are aware of it and those who don't know. Just a sharp or quick review of the whole anatomy of the GIT, or the gastrointestinal tract, how food is ingested and where it's, ends up. Then also we will talk about the, pathophysiology of GERD, how it occurs, then the causes, what really brings about this gastroesophageal reflux disease, how we can diagnose it if, we're at home, we've not gone to the facility yet, or better still, if you get to a healthcare facility, how they can diagnose it. Then we will talk about things that we will see or things that we will feel that will indicate to us that we are actually having this condition. Then, as we are knowing about the signs, symptoms, causes, and things, we also know about if we don't treat it or if we neglect its management, the possible complications that would arise as a result of it. Then we will intervene or manage it, then know how to prevent it with this occurrence so that we don't really get it as well. So this basically the overview of how we're going to understand about the gastroesophageal reflux disease this afternoon, madam.
Thank you so much, Brother Amofa and Brother George. Now that we know what it is about, what we are going to do this afternoon, um, what is there? Could you give us the anatomy of the gastrointestinal system? Thank you.
Great. So with the gastrointestinal tract, or the GIT as we call it, or the GI system, gastrointestinal system, as I said initially, it is the organ or the system, sorry, that enables us to put food in our mouth. Then it will go through the process, then come out as fecal matter, or excuse my words, maybe it's feces as well. So it starts from the mouth. So we know we have our teeth, we have a tongue. So that's where this system starts from. So food will be taken in, then it will pass through our throats, to pass through the that's what we may call it, but pharynx. So that's the junction where the maybe the airway will try to meet um, the GIT. So to pass through that tract through the esophagus. So as the diagram indicates, then to go through the stomach, to go through the small intestines, through the large intestines, through the rectum, then finally to the anus. Now, that is the tract itself, and its length is about 27 to 30 feet. That's approximately 9 to 10 meters. But this system also has its accessories, some organs that are attached to the tract itself. That's the long tube itself. So as I said, the tube, when it gets to the stomach, it will become a bit, bulgy. That's the stomach. Then it will narrow again to become a tube, with small intestines, large intestines, and out through the anus. But these accessory organs, some are the liver, we have the pancreas, we have the spleen, we have the gallbladder. So they are accessory organs that are attached to the tract, but they form part of the gastrointestinal system. So food that goes through can go through directly all the way to the rectum, but the organs that are attached has their own function that they perform. But for the purpose of our study, we are going to focus on the esophagus and the stomach. So we're going to focus much on the esophagus and the stomach to know what really happens with the gastroesophageal reflux disease. Thank you.
Thank you so much, Brother George. Do you want to add anything to it, or we should just move ahead?
Can move on because when you talk about the anatomy, it's just talking about the structure, and that is what Amofa has taken us through. Like God is so wonderful that when we want our viewers to appreciate how God created our system. Therefore, if there will be an error that will lead to a condition that we call death, we will be able to know how to prevent it. Because how can just a common tube. When it reaches a certain point in time, it will inflate. Then at a particular point in time, you see the exit point being coiling again. It tells you that God is powerful and He is our creator. Again, you can see that from the structure God created, from the mouth through to the esophagus that we are seeing. Those sides, they are alkaline, not acidic. That is why any fluid that comes to your mouth will not erode your mouth because it's alkaline. But when it gets to the stomach, you see it becomes highly acidic, especially when food gets into. Why? Because it's going to perform a purpose. And when there is, as we will dive deeper in it, it means when that content is able to bounce back, then we have a condition that we are treating. So let's appreciate the creator and how he has created this gastrointestinal system, and we will be able to take good care of that. Thank you.
Thank you so much, Brother George. So at this point, how do GERD occurs?
Okay, so with the GERD, we are saying that as Brother George ended it, the stomach is highly acidic. The content of the stomach is acidic in nature, unlike our mouth, which is alkaline in nature. So once the stomach is acidic, anything that comes off the stomach to the upper part of the stomach will try to corrode it or erode it, yeah, to be precise. So there will be erosion of the part that this acidic content will get into contact with. So once it's able to pass through that preventer, or there's a sphincter at the junction of the stomach between the esophagus and the stomach. So once the fluid is able to bounce back, so ideally it flows under gravity. So when you eat, food will just flow through under gravity down to the stomach, to the system. But in any case, with any cause that will enable this fluid or this gastric content to bounce back, to be regurgitated back into the esophageal tract, then it will cause that uncomfortable feeling. That is when the lining of the esophagus, the mucosal lining of the esophagus, will be affected. So they will undergo stress, and then this stress will cause inflammation. So once there's inflammation, then obviously you're going to exhibit all the symptoms that you'll be talking about. Um, in the subsequent minutes. So that is actually what this condition is about, how it occurs. So it basically, this acidic contents coming out of the stomach to cause erosion of the esophageal tract, then we will say the person has gotten That's why we say it's reflux. So it's not just about having any acidic content in the esophagus. Someone can ingest any acidic content, but that is not the GERD. This is when the stomach content or the gastric contents itself is able to come out of its original place into the um, esophagus to cause um, erosion of the mucosal lining. Then we will say the person is having this gastroesophageal reflux disease.
Thank you so much, brother, for giving us this explanation of what the GERD is. If we know how it occurs, then we should know what it is. But by then, what causes this GERD?
Okay, so this GERD, as I said, it's not about you ingesting any acidic contents or you ingesting anything that is acidic, which will, in turn, cause this corrosion of your mucosal lining. But then, unless there's gastric content that comes out, okay, from the stomach to the esophagus, then some of the causes could be that maybe the sphincter, the soldier that is responsible for preventing this gastric content from coming out. So as I said, at the junction of the stomach, it's called the esophageal sphincter. So that's the lower esophageal sphincter. When food enters, when it gets to that junction, it will open, it will relax. It's a smooth muscle, so it will relax itself to allow any content to, descend to the stomach. Once it finishes, then it will constrict or it will close by itself, right? So when there is incompetence of this sphincter, or when there is, relaxation, too much relaxation of this sphincter, such that instead of it to close to prevent the, content from bouncing back or refluxing to the esophagus, now it's relaxed, it's not able to perform its activity. Then, therefore, if there's any content or any gastric content, it will have the potential to, get back to the esophagus. Secondly, when this gastroesophageal junction has abnormality, it could be any pathology at all, whether medically or surgically. It could be from any um, how do you call it? From birth, like it could be any cause at all that will prevent this junction from function normally. That is the where the sphincter is really located, the gastroesophageal junction. So if there's too much um, dilated or too much open, definitely is going to also allow for rebounds or reflux of gastric contents. Also, when there is delayed gastric emptying, so when we eat, ideally the food must digest. Then the stomach will digest the food or whatever content that is there, then push it down through the small intestine for absorption. But in cases where food that are ingested end up staying in the gastric or the stomach more than enough, more than necessary, then it has the potential of coming back. As I said, food goes down in flows under gravity, but when it gets to the stomach, the gastric mucosa will take its time to, as it were, digest it well. So in case where there is improper digestion or there is delay in digesting to empty the content, then it will also lead to um, or have potential of causing it to be refluxed into the um, esophagus. That is also another, cause. Now, some contributing factors are increased gastric volume. So, um, I know how I eat. I know I can maybe take a bowl of banku. I can take this amount of porridge in the morning, but I'll end up taking more than I should take. I'll end up drinking more than I should drink. In that case, expanding the gastric um, content. So the stomach is able to accommodate up to a certain level, and it has allowance for free air or free um, what do you call it? It has some space that doesn't need to be filled. But when we're able to eat up to that level, then definitely it's going to also has a potential of causing this reflux. Then our positioning, some will just finish eating, and as soon as they finish eating, they will lie down, or indulging in activities um, that doesn't follow the normal anatomy of the system. Or let's say your position, if you are walking or you are sitting, that's ideal for. That's why it's advised that if you eat, at least wait for about 2 3 hours before you go to bed. Okay, or better still, don't engage yourself in any um excessive activity that would cause movement of the gastric content up the esophagus. So someone will finish eating as soon as possible. He finishes, he hits the road running. As you are running, as you know, there will be up and down movement, and it can cause agitation. You finish eating, you are lying down, you want to watch movie, you want to do this. All these things you do might also contribute to the contents coming out of the stomach. And then when there's increased gastric pressure, okay, so let's say you have um, people who are pregnant, especially. So when you are pregnant, there's a lot of pressure on your, abdominal contents. People who have ascites, like swelling abdomen, um, when these things are happening, it may cause pressure on the abdominal organs, especially the stomach. Then food that are in already, or the contents that are in, may be forced to come out because there's an opening, an allowance for it to be coming out. Therefore, when this pressure increases, it will cause the content to also come out.
Thank you.
Yes.
Brother George, you want to add
Good.
anything, or are you
We
ready?
have
Yeah.
sorry.
Okay. I think he's back. But as he's saying that, you realize that whatever we are saying, we want our viewers to get the clearer picture that GERD is like you having a blender. Then the blender is giving you a volume or a quantity of what you can blend. But anytime that you put more than what you are supposed to blend, the moment you switch it on and the sound begins, you realize that things are now coming out. At times, there will be, because of that increased pressure in there, it will force the covering to even be forcing to come out. And that is what we call GERD. That is what we call GERD. But in our human system, you realize that there is an opening on the lower esophageal sphincter, as he was explaining, the usher to open the esophagus where the food will pass into your stomach. But a situation when there is extra pressure within, because food moving from your mouth into that arena is alkaline. But when food is coming from your stomach back through your esophagus into your mouth, it's acidic. That's where you get the pains, then the heartburns or the chest burns or the heart pain that most people mostly complain of. So we are looking at the things, and another risk factor is age. You realize that when we were talking about the aged health, when it comes to aging, they have slow metabolism or metabolic rate. So it means that if the aged who is not taking care of himself well, you are overfeeding that individual, it means there will be delayed gastric emptying and he will stand at a risk of getting this condition that we are talking about. Then also, certain medications can also predispose someone to having this gastroesophageal reflux diseases. Gastro means stomach, esophageal means esophagus, reflux means bouncing back. So content in your stomach bouncing back to your esophagus is what we call the GERD. So we should put that in our mind. So some medications that we want to give can relax the muscles or can put pressure or increase pressure within, and that can also trigger or predispose an individual to this condition. Another aspect too is lifestyle considerations. There are some lifestyles that can predispose an individual or make that person at risk of getting this GERD. An example is smoking. Those who smoke, what happens is that it weakens the lower esophageal sphincter we are talking about, allowing the stomach acid to flow back into the esophagus. And in that case, we are highly to experience GERD. So over time, the person will be complaining chest pains or heartburns like that issue. So in smoking, it's another aspect. And in smoking also, it reduces saliva production. And when saliva, which is supposed to neutralize acidic environment, is being delayed, it means that there will be no neutralization of stomach acid content, and they can predispose that individual to this condition that we are talking about. And also, smoking will affect you. Remember, within the esophagus too needs blood. And if you are smoking, the impure air would pollute the blood. So impure air or impure blood will be supplied to the esophagus. And remember, in there will be inflammation. And we need certain cells to help, the immune cells to help. But in this case, it's full of smoke. And in that case, it can affect its health. That's why smoking can predispose an individual. Another aspect is obesity. Obesity can also predispose an individual to this condition. Why? Because excess weight will put pressure on the stomach, causing reflux. So with obesity, we've always talked about two types, either the central obesity or the peripheral obesity. So when you gain weight, excess weight, it will put pressure in your stomach, leading to the rebound, and you are at risk of getting this condition. Also, the increased intra-abdominal pressure will also weaken the lower esophageal sphincter, and that individual stands at a risk of this condition. And individuals who also consume lots of fatty foods, you are at risk of this condition that we are talking about. Coffee, alcohol, chocolate also triggers the symptoms. Why? Because in chocolate, we have cocoa, which contains the xanthines. It's an enzyme that we find in it. And that xanthines or xanthine, depending on the school you attended, will weaken the lower esophageal sphincter. And when that happens, that relaxation will lead to bounce back of any content within. And you are likely to experience this condition that we are talking about. And also in chocolate, there is also another ingredient in it that also relaxes the lower esophageal sphincter. That's why it's been mentioned in our presentation. And when you take it, we have sugar, the esophagus. So the sugar in there and the spices in there will cause irritation. And indeed, we are saying whatever occurs should cause inflammation and also affect the esophageal lining. And that's why it can also trigger that. We have a type of hernia that we call hiatal hernia. So as we are having umbilical hernia at the umbilical, inguinal hernia for the males and the females, and we have hiatal hernia, and that has a linkage with the esophagus. So if you have opening of this, and we term it as hiatal hernia, individuals who have been diagnosed of this type of hernia stand at also higher risk of getting this condition. And some medications that we are using to treat asthmatic, some medical conditions like those who are having asthma, and also in pregnancy, anxiety, stress issues can also predispose or make someone at risk of getting this GERD. So as you talk about, these are some of the causes and also the risk factors that we can talk about. Thank you.
Thank you so much, Brother George. Now that we have the risk factors, them or the causes that put us into GERD, we can have the diagnosis of GERD, how GERD is being diagnosed. Thank you.
Yeah, we have added Amofa back. Yeah.
Gentlemen, please, I'm waiting for you. Any one of you can take the lead.
Okay.
Diagnosis of GERD. Thank you.
So I'll begin and my boss might end it. So with the diagnosis of GERD, we're saying we can do barium swallow. So basically, this one is mostly done at the healthcare providing centers. So it's done to evaluate the upper GI tract. So it doesn't descend down to the intestines, but rather it helps us to evaluate the upper parts. So the course that we made mention of, so we'll give you a content to swallow or to ingest, and that will line the upper GI tract for the prescribers or the physicians to assess the states of your upper GI tract. Then we do upper endoscopy. So this endoscopy tool is a device that is inserted that will help us to visualize from your mouth through your esophagus down to your stomach. So it's an kind of a camera, yeah, that has a tube attached to it. So to be inserted down for the prescribers or the physicians to watch, look at what is really, happening in your upper GI. Then there's a Bernstein test. So this one, because you are saying the acid reflux will cause the symptoms. Now we are going to induce it to test to see if really it is good. So once there's an acid that's been mixed with saline or water, then when this is mixed, it will be instilled through your esophagus. When it goes in, and then you feel the symptoms of GERD. So we have now induced acidic, unlike the natural one that the gastric content will rather be reflux. Because we want to test it. Now we induce these symptoms for you to feel the pain or the discomfort. If you feel it, then that means it will be indicative of GERD. And then we have the 24-hour ambulatory esophageal pH monitoring. So 24-hour ambulatory. So you give a device that will track your activity for 24 hours. So it is placed on your chest region along the esophagus. Then to monitor your pH throughout the day. So as you walk about, as you do activities, or even if you are in bed confined, it will still monitor the pH of your esophagus. Then it will give indication whether there's really acidic content coming into your esophagus or not. So these are the diagnostic investigations or the tests that are mostly done to confirm diagnosis of the GERD.
Thank you so much. Brother George, do you have anything to add? Or
Yeah, I think basically this is the summary of the diagnostic tools that we use to confirm. Because why we are doing this is that so many conditions can also mimic the symptoms that we'll be talking about. But we want to confirm that whatever you are talking about, is it really the gastroesophageal reflux disease or different condition? That's why we do this as well. Thank you.
thank you so much. If we know the diagnostic tools or how the GERD is being diagnosed, then we must as well talk about the signs and symptoms of GERD. Thank you.
So with the signs and symptoms, because it's about the upper GI, and then its location, it's within the chest cavity, down to the just below, a little below the chest cavity. So most of the symptoms are going to be experienced at that region. So we should take note. Most of the because the esophagus just pass through behind the sternum, then in front of the how do you call it, the vertebral column. So most of these symptoms are going to be experienced at the chest region or the thoracic cavity. So we are saying that a person will experience heartburns. Okay, so the burning sensation that will be felt under the sternum or in the throat. So I believe most of us have encountered some similar burning sensations in our throat or just beneath our chest. There's the breast bone. That's what we call the breastbone. That hard one that lies between our breast. That's the sternum. So this pain or the burning sensation we felt mostly at that region or that angle. So that is one symptom that we um tell us that probably you're having a reflux of acidic content into your esophagus. Secondly, there will be chest pain. So your chest will pain. It may be squeezing, it may be burning. That you feel more common in adults. So as Brother George said, with the diagnosis, it's able to help us to distinguish between other mimicking conditions that can be similar to the GERD. Okay, so someone may have tightening of the chest, squeezing of the chest. It may not be GERD. Maybe it's associated with any heart condition. It may be associated with the lungs or some other organ. Okay, but with this, we are saying it also burns. It squeezes and it burns. So we can do the diagnosis test to determine whether it's really good or you're having other conditions that has similar presentation. Also, there's dyspepsia. There's dyspepsia. So when we are ingesting, there's pain, there's discomfort in the upper GI. So that is another symptom. Then regurgitation, as you have been talking about, it's just coming out. So that's the reversal of content from the gastric region. So you feel some bitterness or sour liquid in your throat or mouth. So once there is reflux, it will come all the way up. Then you feel nauseated. Your mouth will feel some kind of bitterness. That's it. You feel nauseated some way. It's like you've taken some lime. Your mouth will be, tasting sour. So that is another symptom of the GERD. Then cough, because when the contents are coming out and your airway is not protected, it may end up escaping into the airway itself. That's the trachea. So once there is escape of this content into the trachea, then your reflex your body will tell it to bring it out. So you'll be having coughs. So coughing out the content or something that has entered into um, your your throat, or better still, your trachea, will give an indication of maybe probably a GERD as well.
Thank you so much. Now that with every disease, every condition comes with complications. Please, would you be able to identify the complications that comes along with it?
Yes. So with the complications, I was able to align these three basically because most often this condition is not mostly talked about because sometimes we feel like, oh, it's normal, you just ate and you are feeling these discomforts, so mostly we don't really take good notice of it. But some complications that may come up because of the acidic content, as it keeps on eroding this esophageal mucosa, as it keeps on straining or irritating this mucosa, is definitely going to increase the inflammatory processes. So you are going to have esophagitis. So there's going to be inflammation of your esophagus. That is one complication. So if it's a normal, maybe one time reflux that was resolved, in no time, there may be, no esophagitis because um, the body will be able to, once you even swallow saliva, because of its alkalinity, it's in a way going to neutralize that as part. But if it becomes continuous, consistent, then the inflammation is going to be, prolonged. Is going to cause serious complication as esophagitis, which will be needing treatment or management. Then the second one is the Barrett's esophagus. The Barrett's esophagus. So the mucosal lining of this esophagus is mostly flat epithelia. This one is technical though, but it will be changed to some other cells. Then these cells are having tendency of leading to cancer. Okay, so once they said the original cell that God made, as George said, we need to appreciate the nature of our body, how God made it. So if there's any alteration to any part of it, then it's a pathology. It's something different that the maker didn't put there. Then this has a tendency of leading to serious cancerous diseases. So there could be adenocarcinoma. Okay, so that being said, we should just be worried when this condition is actually aggravated because we don't want it to end up giving us any cancerous feeling. Then there's going to be respiratory complications. As I said, once there is um, aspiration, once you get aspirated of any content from whether from the mouth down or from the stomach up, you have to bring it out. So there's going to be cough. But if it becomes so severe, then the cough is going to be very, very complicated. It's going to be consistent. You have to, as it were, due to the corrosion, your body will feel like there's something that is attached there. So bring it out, then the cough will be aggravating. There could be bronchospasm. Okay, so your airway proper could enter into spasms, which wouldn't be so good for your breathing. It would really, really affect your breathing. So that's a complication of this GERD. Again, there's going to be laryngospasm. So the bronchospasm, laryngospasm, the larynx will be entering into spasmic mood, like it wouldn't get the time to relax or contract properly. So to be kind of fidgeting, maybe lack of better words. So that's going to be also another complication. There could be bronchitis. So from the trachea, you go down to your, primary bronchus. So that aspect too, if the content enters to that angle or it goes down to that level, corrosion will still be, increasing, which will cause inflammation of the, bronchus. Pneumonia, so that's just typically uh, inflammation of the lungs. So as there's any irritation to the respiratory system, it will cause um, uh, when you aspirate this content, it will have, also lead to the inflammation of the lungs itself, which would end up giving you pneumonia. So these are some complications. But I George add something.
Okay, so you realize that what we are discussing initially, you just mentioned it. At times, people think that, oh, for some time when I eat, then it bounce back, then they will complain, then it will go. So people take it lightly. That's why when our viewer asks of this question, we want to address it holistically with all the approaches. So you realize that just a rebound back of stomach content can cause all these complications. And it means that when you continue to neglect and refrain from whatever triggering or causing it, that's where it can reach. And when your lungs are being affected, when the esophagus is being affected, then it means nothing is entering. And when inflammatory procedure sets in, it's through your mouth that things will get into your stomach, your heart, every organ of the body. It means there will be a chaos in all the system. So in a mega summary, this is what, when we neglect to take care at the initial stage, we can enter. And we don't want our viewer and our listener to enter into this complication. That's why we are creating the awareness for you also to have knowledge. Thank you.
Thank you so much, gentlemen, for giving us this in-depth understanding of the complications of GERD. Every disease that has a complication has a way that we can manage such conditions. Therefore, how can we manage, or what are the management options for GERD? Thank you, gentlemen.
So with the management, we will talk about other or different forms of management. So ideally, I wouldn't want to go into pharmacological interventions initially. Personally, I would like to do modification, things that would help to prevent it, or that would reduce the risk or the potential of getting such condition. Or even if it happens, there are some modifications that could be done to really avert it before it becomes complicated. But for the sake of our presentation, we would go into the pharmacological intervention. So we are saying we can use antacids. So some will say anti-acids. Yes, that's basically that the word anti-acid. So because the acidic content came out to the esophagus, now we want to give it something to neutralize the acidic content or to neutralize the acid that is in the stomach. So antacids are given to just increase the pH. So when pH is increased, it's entering the alkaline state. So you want to increase it from its acidic medium to an alkaline, from neutral to alkaline medium, so that there will be balance. So that even if there is going to be reflux, it wouldn't cause much chaos in the esophagus or to other respiratory system to cause the complication. So some examples are the magnesium salts. So some would go by and magacid, some will go by the trisilicate. So these are some of the examples that I can give for the antacid. So they are all, I mean, they help to reduce the acidic content, then also to deactivate pepsin, technical do. Now we also have the H2 receptor antagonist. So the histamine 2 receptor antagonist, also they block the histamine receptors. Okay, so and then they decrease the gastric acid release. So these are systems that are put in place to help your body to produce the acid, because acid is really important for the stomach. That is its medium. Like that's why it survives. It works better. Without acid in your stomach, a lot of digestion, a lot of procedures or processes will not go on in your stomach. So it's really an acidic medium. But when it becomes excessive, or when there is a pathology that this acid is causing other complications, we now want to reduce it. Okay, so we want to be a little bit balancing here so that it doesn't cause much problem. So we give these medications also to reduce the gastric acid release into the stomach. So we also have the prokinetic drugs, which also helps to empty the stomach. So because the causes, we said, when there is prolonged stay of contents in the stomach, it can cause the regurgitation. Now you want to empty it faster. Okay, the tube is blocked or the pipe is blocked. Now you want to push it out so that the content that is coming can also move freely. So you give some medications that will help us to empty the gastric contents as soon as possible. Then, of course, we have the proton pump inhibitors. These are medications that also decrease the production of the gastric acid. So, similar to the H2 receptors, these ones are just going to reduce its production. Okay, so um, the organ, or should I say the system responsible for production of the gastric acid, will be inhibited or will be prevented in a way. We will just block it for a while so it doesn't produce much of the acid. So we also have some medications that are responsible for that. So these are the pharmacological intervention. With a lifestyle modification, Brad George will hammer on that very, very well. So that is for the pharmacological. Now, the second one is the surgical intervention. So when we are giving these pharmacological interventions and we realize that there is the need to go in to, provide surgical intervention such that the, the, the symptoms will be relieved for probably as a long-term solution. So we can enter into the surgical mode, which the procedure done is the anti-reflux surgery. So the part that I said mostly don't need to be filled with gastric content or with food or with any thing we ingest. That part will be used to wrap around just to solidify the lower esophageal sphincter. So we are saying that when there's incompetency of the sphincter, that will cause it. So now we want to reinforce the sphincter, like to hold it firm so that it will be able to hold up anything that enters it. So that is what this anti-reflux surgery is also used for. So it helps to reduce this reflux by reinforcing the lower esophageal sphincter. That's for the surgical intervention. Now moving to um, the lifestyle modification, we are saying there is nutrition therapy. Yes. So as we said, Brad George made mention of the foods that we eat that has the potential of either delaying digestion or has the potential of, causing us to has this reflux. It's also important for us to know the things we eat, the things we do, so that it will prevent us from entering into that mode. So we should limit foods that decreases the pressure in the lower esophageal sphincter. So you made mention of the chocolate, the high fat foods, the carbonated beverages, the coke, and those things. Not, um, advertising against any company though, but we are just talking about our health, things that are good for us. That's what we are talking about. So these carbonated drinks or beverages are potential causes of increasing risk of pressure in the lower esophageal sphincter. Also, there should be limitation of foods that irritate the esophagus proper. So for most of us, we want to take spicy foods. Okay, we want to take very hot foods. We want to take these things that would please us, not thinking about the health implications that they will bring onto our lives. So we should also be mindful of such foods like the spicy or the acidic foods. We should be, very cautious of these foods so that we don't aggravate our symptoms or likelihood of entering into complications of this GERD. Then we should also be eating smaller meals, okay, and then should stop eating at least 3 hours before bed. Some people also are very good with, in between meals. You eat breakfast, small time, you eat this, small time, something is in the mouth. Okay, these are all things that would actually reduce emptying of the gastro contents. That may end up being a tendency of causing this gastroesophageal reflux disease. So we should be mindful of such, foods that we eat. So, Bajo, I don't know if you add something to the nutritional therapy.
Thank you. So what we are discussing here, you realize that the main focus is that we have some category of people who are on some medications, but they mostly continuously experience this condition that we are talking about. And we have someone who is also about to enter into it, but you realize that when we are talking about, we want to look at how one we can be able to neutralize the acidic environment within. And that's why he was mentioning about the antacid. So per our lifestyle modification, you realize that currently per researches and things, you realize that activated charcoal is one of the things that also neutralizes acidic environment. At the same time, it's able to help aid in proper digestion and proper emptying, so that you not be feeling bloated, of which can lead or can predispose an individual to rebounding or reflux of this acidic content in the stomach. So it's also very important that we include acidic activated charcoal in our daily life, and you can do it with warm water. Let's say a teaspoon with water, like half glass, which is like 250 mils. Then after taking it, you make sure you drink a lot of water, and that will also help you. Another aspect that will also help us neutralization is cabbage, common cabbage. Cabbage has something in it that we call vitamin U. And this vitamin U also serves the work like antacid. It neutralizes acidic environment or acid in your stomach, that the antacid that we mentioned can do that work. But the cabbage can help you a lot. And you know, if you have not grown for yourself, when you buy your cabbage, when you are going to buy, make sure you buy the one that the insect has been able to attack, not the one that is very nice like your face. No, buy the one that you think is ugly. And just when you get into your house, you just get a charcoal solution with water and soak your cabbage in it, so that it can be able to also take any harmful toxins that get into contact with it. Afterwards, you can blend it, then you strain it and you take as a juice. And that is when it can serve that vitamin U neutralization reaction. Or you can also take it as a form of salad, and that also helps in that aspect. We want to prevent rebound of this acidic content out. Therefore, we want to encourage that. Don't encourage or entertain food competition where like everyone want to swallow rice. You want to swallow, so you crown you like the champion in the food competition. When that happens, you goes against the laws of eating, a healthy eating habit. And in that case, when chilled foods are not chilled properly, it means when food gets into the stomach, more acid needs to produce to come and work on that hard content before it will dissolve it and before it can be able to work on the food itself. So when you chill proper food well, it can aid in early emptying than you eating swallowing chilled food. And swallowed foods should also be made in soft but not hard, so that it can also lead to quick emptying but not bloated. That will make you feel full. And little thing, there can be a rebound. So as we are doing whatever we are doing, then we make sure we also pay much particular attention to this. Water is very important. It's a natural alkaline that neutralizes acid. So we want to encourage that. Let's be hydrating ourselves. Let's be drinking a lot of water, so that the mouth, it will not be dry, because we want the production of saliva to continue, so that neutralization can occur. But if you are not also drinking water, it affects your mouth, your esophagus, and it will affect your stomach as well. But since it's also good, do not mix water with food. So you take one food, then you take water. No, in that case, it affects. Note that all improper eating habit or unhealthy eating habit will affect this condition that we are talking about. So we need to also take note. Then another research also proving that omega-3 fatty acid food reduces inflammation of this GERD. And because GERD, we have talked about the inflammation process that occur. So like the chia seeds, the flax seed, and the other seeds, you realize that when you are taking them in variety, it contains this omega-3 fatty acid, which naturally will help you and reduce this inflammation. Then also, research have also proven that ginger also decrease GERD symptoms. So we want to encourage our individuals that let's include ginger in our diet. At times, you can also, when you feel those pains, you can just chop small, put in your mouth like your toffee. Instead of taking a gum, put ginger rather in your mouth, and it will be able to help decrease the GERD symptoms. Then also, it has been proven that behavioral activities can also affect this condition. So your behavior, what can you do? We are talking about smoking being affecting our health in this aspect. So you need to quit smoking. Then also alcohol consumption too, you need to avoid it. Then also positioning, especially we will talk about positioning more for those who are bedridden. Make sure if you are nursing someone in the house who cannot move, who cannot do anything, and you want to feed, make sure you raise the head end of the pillow or of the bed with pillows so that there can be gravity of descension. As at the same time, you also who can walk, talk, and do anything like we are also doing, you make sure that you don't sleep immediately after eating. Then also you need to make sure you avoid drugs that can lower the lower esophageal sphincters, and we have talked about. So anytime you want to take something, please seek counseling and proper guidance before you embark in any of these things. And also we have known that, or research have also proven that individuals who lack vitamin D, they are also at risk of this condition. So let's expose ourselves to the free gift, less expensive vitamin D sunlight. Let's be exposing ourselves to the sunlight. You can do the sun bath where you come and sit in the sun with your chair. Then you can use a napkin or a handkerchief to cover your eye. Then you sit and just within the sun. And that exposure will help build your immune system, be able to fight against inflammatory process, and also decrease your risk of getting this condition, GERD, that we are talking about. Then also, we need to make sure that individuals who chew a lot of chewing gum, so they chew a lot of gum without swallowing, you know it's not a food. So the more you are chewing, the more acid is being produced. And the more acid is being produced, but nothing is being swallowed, that can also trigger this condition that we are talking about. So in summary of our education, we are saying today that when we talk about GERD, which is gastroesophageal reflux disease, in a simple term, it means that the backflow of acidic content in your stomach into your esophagus. And this condition is affecting a lot of people. And if you are not careful, it can lead to the complications we've talked about. But you can do a part by preventing yourself from this. Even if you are on medications on this condition, you can also do a part by making sure whatsoever medication need to add lifestyle modification and be conscious about it so that it will not reach the complicated stage where surgical intervention and other things will come in. So on this note, this is a summary of the lesson that we have studied so far. Thank you.
Thank you so much, Brother George and Brother Enoch, for giving us this in-depth understanding of gastroesophageal reflux disease, which is also known as GERD. They have made us aware of what we can do to prevent ourselves from getting it. However, in case that comes a long life where you will know what to do, when to seek for medical attention, and when to report it. Don't let us keep our symptoms by ourselves. Sometimes you want to keep ourselves to ourselves, but sometimes you need someone to guide you through. God will not just descend from heaven to come and heal you straight away, but sometimes he has to take you through some steps, through some people. Let us speak up. Don't die with your symptoms, but rather seek for help. It has been a great day, a bright Sunday. The sun is going down, but we will still call it a bright day. Therefore, we thank God for bringing us to this far with our brothers, Brother George and Brother Enoch. We say, may God bless you, and to all our viewers and listeners, we say, may the good Lord continue to bless you as you continue to be with us throughout this program each and every Sunday. This program is coming to you right from Richmond Media to your doorsteps. My name is Hanna Bimah. The same time again, UK time, 3 p.m. next Sunday, we are meeting right at Richmond Media. Until then,
Say